Good morning, and thank you very much for the invitation. Really appreciate it. My task today is to speak about atherosclerotic plaque structural composition and how it can affect our decision making. I have no financial disclosures, but I do want to make a shout for my preeminent mentors at the University of Chicago who have really contributed in a seminal way to our understanding of hemodynamics and atherogenesis. And this is an introspective review, actually, of 3 decades of research at the University of Chicago, at Erasmus, and at Henry Ford Hospital. I think we all know that carotid interventions are appropriate in preventing stroke and death in patients with symptomatic disease, more than 50% stenosis, but the debate continues for asymptomatic disease. And we have to understand that what is inferred by carotid disease has been mostly focused on degree of stenosis, which I think is a limitation. And we have to pay more attention to plaque burden and structural composition if we're going to make intelligent decisions about how to treat asymptomatic disease. And we also have to understand that carotid plaques have different structural composition for a given degree of stenosis, and that different territories have different structural features. We stand here congregating in a land where the glorious pyramids are, and they have withstood the test of time as far as structural integrity. That is not the case for carotid artery plaques. Now there is compelling evidence that the pathogenesis of such ischemic events are consequential to plaque rupture. And I should say that it is very unusual to have a stroke in a patient because of decreased hyperperfusion, unless there are 2 or 3 carotid or vertebral vessels involved and a 𝗔𝗀𝗃𝗃 of Willis anomaly. So I will review very quickly the evidence here. We do have randomized controlled trials in symptomatic carotid disease, and the NASA trial is one of them, published in 1991. And it does show that indeed surgery is much better than medical treatment, although this was a long time ago, for treating high-grade stenosis. But what stands out quite significantly is that ulcerated plaques have a much higher incidence of stroke than non-ulcerated plaques. So that gives us a clue as far as plaque structure at the outset. The second thing is that histopathologic analysis of symptomatic and asymptomatic plaques removed at endarterectomy provide us with significant knowledge regarding the structural morphology. Back in 1997, we devised a technique to remove the plaque in toto without cutting through the plaque, and that allowed us to actually look at the topography of the sections and how different features of the plaque are related to the lumen. And it was very obvious to us that the juxtaluminal location of the necrotic core in a vanishingly thin fibrous cap was a precursor of symptoms, and that was quite evident in the symptomatic plaques, but not present in the asymptomatic plaques. So we've reached some idea on what the structural features are of the unstable carotid plaques: plaque necrosis and its closeness to the lumen, a thin or absent fibrous cap, inflammatory cell infiltrate and plaque neoformation, thrombus, interplaque hemorrhage. As far as calcification, we're still learning what the value of that is in carotid plaque instability. The third evidence comes from X and in vivo plaque imaging, and there are many ways to look at the plaque: duplex ultrasound, CTA, magnetic resonance. I will focus on ultrasound and MRI and CTA. Back in 2005, we looked at carotid plaques grayscale median analysis using a standardized way, and we found out that symptomatic plaques had clearly a lower grayscale median analysis or number than asymptomatic plaques. So echolucency of the plaque does provide us with some idea as to whether the plaque is stable or unstable. And interestingly enough, we found that females had more echogenic plaques than males. This was maybe in line with the 𝗖𝗂 study earlier on. And in fact, the juxtaluminal location of plaque necrosis was found to be evident in symptomatic patients on ultrasound, what was described by Kakos as the black hole on duplex ultrasound. Now, I find CT angiography quite advantageous from a quantitative aspect, and using software methodology, you can actually look at plaque burden, 3D structural topography, of the regions, soft regions, fibrous regions, and calcific regions, and also look at the percent stenosis. Obviously, it does have its limitations with contrast administration and radiation exposure. And these are two studies that we conducted at the University of Chicago, and basically it shows that asymptomatic plaques have greater calcium than symptomatic plaques. And indeed, the amount of calcification was inversely related to the inflammatory aspect of the plaque, the macrophage count in these plaques, as evident in this regression analysis. Furthermore, there was also transcriptional evidence that patients with non-calcified plaques had more pro-inflammatory markers than calcified plaques. Furthermore, I pursued this area in Erasmus University, and we looked at the structural analysis by CTA, and this was a study that was conducted at Erasmus. I don't think it's finished yet, the Plaques at Risk study. It's a prospective multi-center study to improve the diagnosis of high-risk carotid plaques, and they were going to recruit 300 patients. These are patients with 30 to 70% stenosis not scheduled for intervention. And interestingly enough, these patients had on one side the stenosis, on the other side, one side symptomatic, the other side asymptomatic. There was no difference in the degree of stenosis nascent or ECST. Also found that a lot of these patients had different patterns of calcification, which is another facet that has not been studied adequately. The findings of the study really showed that the volume of the plaques in the symptomatic patients for a given degree of stenosis was greater, and low-density Hounsfield unit areas were much higher in the symptomatic plaques. Furthermore, it was interesting that the total plaque volume was not related to the percent stenosis with both the ECST measurement and the NASCET trial. And this is not surprising because the 𝗔𝗀 phenomena tells us that as the plaque enlarges, the artery also enlarges. So there's an adaptive enlargement until the lumen stenosis reaches about 40%. So you could have a fair amount of plaque burden without a significant stenosis. And these findings were really supported by other meta-analyses that were published, that soft plaque, ulcerated plaque, and calcified plaques are all factors that influence the predictors of symptoms. One area that has not been really studied is the flow dynamics of these stenosis, because shear stress, I think, may play a role in plaque rupture. So now with current medical therapy, we have reduced the risk of symptoms from or symptomatic outcome in stenoses. And in 2009, Ann Abbott showed us that, in fact, with current medical therapy, you can reduce the risk of stroke from asymptomatic plaques to levels even lower than the risk of endarterectomy. So in summary and conclusions, juxtaluminal low-density regions are significantly greater in symptomatic plaques and inversely correlated with the degree of calcification. Plaque burden itself is important, and finding juxtaluminal low-density volume was associated with symptoms and not the degree of stenosis in this last data set. So I think CTA methodology can give us a lot of information on whether the plaques have the propensity for symptoms or not. Unfortunately, all the natural history studies have not really examined these structural predictors in asymptomatic plaques and long-term outcome, and they need to be done. And finally, I would like to recap what Professor Naylor said about the guidelines. Currently, the ESVS guidelines for the high group asymptomatic patients include all the features that were mentioned in this presentation. Thank you very much for your